Next, I'd like to talk something about the diagnosis of tuberculosis. To diagnose tuberculosis, physicians need high index of suspicion. We need to find high-risk populations, especially those with typical symptoms. A classic chest radiograph may help physicians to do the diagnosis. Mycobacterial culture is the gold standard of diagnosis of tuberculosis. Acid-fast bacilli microscopy, no matter light microscope or fluorescence microscope, may help us to find acid-fast bacilli. Nowadays, we have some new technique to help physicians with the diagnosis, like nucleic acid amplification technique. And also, we may have some new technique for culture, that is mycobacterial growth indicator tube. We can also do the drug susceptibility testing. Tuberculin skin test can also help us to do the diagnosis. T-spot or interferon gamma release assays can also help us with the diagnosis. We don't have enough time to go through all these tests one by one, so we're gonna look at TST, that is tuberculin skin test, further. Skin test reactivity is actually based on DTH, that is delay type hypersensitivity. There are previously sensitized CD4 positive T lymphocytes involved in this reaction. A positive skin test reactivity means the patient has already have protective immunity, but this type of immunity to TB does not guarantee full protection from TB infection. To do TST, we need a standard dose of 5 tuberculin units. We inject tuberculin intradermally on patient's inner forearm, just like this. How do we read the results? 48 to 72 hours later after the procedure, we measure the diameter of induration in millimeters. Please pay attention that if the patient have no induration, then the result should be recorded as 0 millimeter. Erythema or redness is non-specific, should not be measured. This is how we measure the induration. Induration is the ridged, hardened area. We measure it perpendicular to the forearm. Thank you for your attention and patience.